Good afternoon, everybody. This is Scott Balthazar. I'm with Advantage IR. I'd like to thank you for taking time out of your day today to hear a wonderful presentation from Dr. David Wood and Dr. Sandeep Mistry on PAE. So a few quick introductions, and then we'll get going. One big note, if you've got any questions that pop up or anything that you'd like to ask about, go ahead and type them in. There should be a chat window within your Zoom to allow you to type in that information, and then we'll make sure to try and get those questions out to the doctors before the end of the call. If not, we'll get you emails directly after the call to get those questions answered. So let's get things rolling here. Prostate artery embolization, a non-surgical FDA-approved alternative to TURP, is being used to successfully treat benign prostatic hyperplasia. So today we're going to talk about what is PAE, how does it provide relief from BPH without sexual side effects, and more. So today our primary speakers are going to be, first, Dr. Sandeep Mistry. Dr. Mistry grew up in the Houston suburb of Sugar Land. He went to college at the Illinois Institute of Technology in Chicago, where he earned a degree in chemical engineering. After college, he moved back to Houston and received his medical degree from Baylor College of Medicine. While a medical student, he was awarded a prestigious Howard Hughes Research Fellowship to conduct basic research in prostate cancer. Dr. Mistry stayed at Baylor to complete his residency in adult and pediatric urology, and while a resident, he earned his master's in public health. He is now with North Austin Urology, and he'll be our first presenter when we get things rolling. Our second presenter is Dr. David Wood. For 14 years, Dr. Wood has specialized in micro-invasive targeted treatments for a variety of health problems, guided by state-of-the-art imaging technologies. Dr. Wood obtained his medical degree from the University of Southern California. He stayed on at USC for specialty training in diagnostic radiology, followed by subspecialty training in interventional radiology. He is double board certified in diagnostic radiology and interventional radiology. So those are our panelists today. They're going to be presenting to you, and I believe we're going to kick off with Dr. Sandeep Mistry. So I'm going to make you the host, Dr. Mistry, and let you get talking.
Thanks a lot, Scott. Hopefully everybody can hear me. I'm going to just share my screen here so you guys can see my slide deck. If there's a problem, please send a little message. So many of you on the call today are patients of mine. Certainly most of you are patients of the practice. If you haven't seen us in a while, we have 4 physician practitioners, we have 5 PAs and nurse practitioners, and we do the entire range of treatment for enlarged prostate, which makes up about 20 to 30% of the patients that we see. Some of you may be aware that we have a show on KLBJ News Radio. It's the Armor Men's Health Hour. It's also a podcast. We'd encourage you to get information on prostate artery embolization, the remainder of our BPH therapies, and so much of what we do wherever you get your podcasts. And if you'd like to know more about that, just message us and we will send you a link to it. Prostate artery embolization is a procedure that I first became aware of when I was a resident almost 2 decades ago. It was done mainly as an emergency procedure when you couldn't control the bleeding after a surgical procedure. But how we kind of conceptually thought of it is the interventional radiologist could go in there and find the arteries feeding the bleeding vessels and stop that bleeding. Since that time, the instrumentation to do the procedure, as well as the indications for it in terms of BPH, have expanded. You'll hear very little about prostate artery embolization from most urologists, mainly because it's not performed by a urologist. And so we call it turf battles in medicine, when 2 different types of doctors share a common disease or diagnosis, that sometimes they don't work together. But I've tried very hard to, turn that kind of philosophy on its head. There's a number of reasons people don't want to do traditional surgical or medical therapy for enlarged prostate, and for them, prostate artery embolization may be a great option. So big thanks to our team here, and I really appreciate you guys all joining us today. When we talk about BPH, we're talking about enlargement of the prostate that can lead to 2 different kinds of symptoms. Some of them include blockage symptoms like slow flow, incomplete bladder emptying, potentially the development of urinary tract infections or bladder stones, and hesitancy, which is a delay in getting your urine flow started. Irritative symptoms can include urgency, frequency, leakage when you can't get to the bathroom fast enough, nighttime urination, and even some blood in the urine. There's also the symptom of dribbling. So if you're having to spend a lot of time shaking it at the end because of a concern about a stain in your underwear, that would be something that we call post-void dribbling. Then that's also a symptom of BPH. This is a list of all the traditional BPH treatments that have been offered in the past. There are medications. Common names for that will include tamsulosin or finasteride. There are procedures that we perform, all of which here in the office: Eurolift and Resume, Aquablate. These are the more minimally invasive type procedures that have become more common. Eurolift uses a titanium clip attached to a suture that pulls the lobes of the prostate aside. Resume, we use a small needle to inject vapor or steam into the prostate gland that causes it to shrink. Aquablate uses almost water like a knife to cut the prostate tissue out. TURP, or Transurethral Resection of the prostate, is kind of the traditional Roto-Rooter. It still remains the gold standard of getting rid of prostate tissue. And then there are uses of lasers. Green light and holmium lasers have been used to shrink the prostate. It's a lot of different treatments. What that means is that there's no right one for everybody. If we already had the answer, we'd just have one treatment option. Each of these is associated with its own set of side effects. Medications like alfuzosin and Flomax can be associated with side effects like retrograde ejaculation, and they can be associated with dizziness, like what we consider orthostatic hypotension. That's when you're dizzy when you stand up. They can also cause sexual side effects like difficulty with achieving orgasm. Finasteride and dutasteride are also medications, but they can also be associated with long-term complications of low sexual desire and erectile dysfunction. So in our clinic, we don't use a lot of those medicines, except in the one scenario in which somebody has a very large prostate and they're not sexually active. Then dutasteride and finasteride can be helpful in shrinking the prostate. And then for a number of patients, we use daily Cialis. It's kind of a two birds with one stone kind of approach. We're able to reduce BPH symptoms. This medicine traditionally works for the irritative symptoms. So urgency, frequency, and frequent nighttime urination are where this medicine can usually have a big impact. And it also helps you get better erections. So that's a nice little side effect. The pros of the medication are they're cheap, but the side effects that I mentioned can sometimes limit their long-term use. And we try to keep long-term use of tamsulosin to a minimum. Most patients, it doesn't work for more than 5 years anyway. And long-term use can lead to chronic fatigue. The Eurolift procedure, some of you may have already even had it. If it didn't work, then that could be one big con. It doesn't actually reduce the size of the prostate, and the surgical skill level is very important in terms of overall success. But what's good about it is that it's a simple and quick procedure. Some people do it in the office, although I don't. I do have two partners here that do perform it in the office, and it does not cause retrograde ejaculation. And the lack of sexual side effects is one big reason why that procedure has become very popular. Resume is also kind of more popular. It's quick and easy. It's done here in the office. It takes less than 9 minutes. It's very quick, but it does require a catheter for at least a week. And some patients can have urgency symptoms afterwards. But if you have an enlarged prostate and going to the operating room is something you're not particularly interested in, this is a potential option for you. Next, we have Aquablate. It is a cutting-edge technology in which a water knife is used to trim or cut parts of the prostate out. It does require general anesthesia. It's not covered by some insurances, and it's only good for big prostates. There's no heating, but you do have to get off blood thinners if you're on it. And it's not something that's really very routinely performed. The number that are done every year in the United States is lower just because of that insurance coverage issue, but it may be something that we hear about more in the future. But it is cutting of prostate. It's just using, instead of heat or lasers, it's using water. Next, we have the transurethral resection of the prostate. This is the gold standard. I do probably 3 or 4 of these a week. It's great for prostates of almost any size. It does require a catheter, and in my case, I do keep people overnight in the hospital, although some people don't do that. It's widely available. You can get it done. You know, I did TERPs on medical missions in foreign countries. It's a simple set of instrumentation, and it's widely understood how it's done. There is a risk of bleeding. It does, and it will for certain cause retrograde ejaculation. And for many patients, that will be a permanent thing. Green light laser vaporization essentially uses energy that's produced via a laser that is absorbed at a certain wavelength that desiccates and dissolves the tissue. It's super cool to watch in terms of the procedure, but it doesn't take out as much tissue as the TERP does. It doesn't bleed as much. So one of its biggest benefits is that in certain circumstances, you can stay on your blood thinners. So sometimes we get people with fresh cardiac stents who can't get off their Plavix. Those are people who end up being good candidates for the green light laser vaporization. You do have to get a catheter for about 3 days. And it doesn't work very well if you have urgency or frequency as your main symptom, because it's that laser wavelength in some patients can make those symptoms a little worse. So it's good if you just have blockage, and less if you're getting up 5 or 7 times at night. The holmium laser nucleation is something that's getting a lot of kind of marketing and advertising coverage here in Austin, because somebody came in town that does a lot of them. It can be performed on large prostates. I've done several hundred of them. It does require catheterization, but sometimes you can get sent home the same day. It's not for everyone, meaning not every surgeon can perform it. It's a technically complicated procedure that takes up to 3 hours. But there is a minimal bleeding risk. And if you have a very large prostate and you're not looking for a laparoscopic case, this could be an alternative. Most prostates are about 30 grams in size, which is about the size of a walnut, but prostates can grow very big. I've had prostates in the 400 and 500 grams. That's almost 20 times normal size. And those are softball sized prostates that require different instrumentation and a different mindset when it comes to surgical intervention. I also performed the laparoscopic simple prostatectomy. There's probably only 3 or 4 people in the city that do them regularly. These are standard of care for prostates that are more than 3 times the normal size. It's a laparoscopic approach. It does require a hospitalization, and you do have to get catheterized for a week or 2. But it's great because it works very well to remove large pieces of prostate, and you can also remove stones. But it will cause retrograde ejaculation, and you know, all the risks of a transabdominal surgery are experienced. And then just from the urology standpoint, how we look at prostate artery embolization, it fits a wonderful niche for those of you out there that are highly reluctant to have anything put up your penis. So it happens all the time. The moment I explain the other procedures, it's almost like the air gets sucked out of the room, the thought of having to wear a catheter or anything going in the penis. There's also a good number of patients who would like to eliminate the risk of any sexual side effects, even retrograde ejaculation, which many urologists may not take seriously, but I know causes people some grief to think about. And what retrograde ejaculation is, once again, is just when you ejaculate, you have a normal sensation, but no fluid. And I have patients that come to me after TERP wanting to get their ejaculation back, and I have to tell them I can't do that. So for some men, it can be a upsetting outcome. Excellent clinical outcomes. We've been doing them with our patients for some time now with excellent outcomes. We have patients telling us that they're getting improvement in their urinary complaints within 3 or 4 weeks. We're getting people, we've actually had 2 just in the last week that said their sexual functioning was better. And we've had, very good results and and feel confident in that relationship with advanced IR. And I know Dr. Wood's going to specifically walk you through what that procedure is and what to expect from it. It can be performed on a wide variety of prostate sizes, although in my opinion, very small prostates don't do particularly well. Minimal recovery, no general anesthetic, no Foley catheter. And if it doesn't work, everything else that I talked about is still on the table, so it doesn't burn any bridges to do it. I mentioned that many urologists don't speak about prostate artery embolization because it's not performed by a urologist. And there are very few specialty centers. So oftentimes you're going to get an interventional radiologist that doesn't do a lot. In fact, because of insurance reasons, some of our patients are sent to ARA or Austin Radiologic Association to get it done. And 9 times out of 10, they refuse the service because the interventional radiologist doesn't have that experience. So partnering with a group like Advantage IR has really helped us accomplish the goals that we're trying to, which is to get the right treatment in the right hands of the patients. So Scott, I'll send it back to you to talk to David.
Great. Let me get Dr. Wood here set up. Or Dr. Wood, we're going to go ahead and transfer the control over to you here. Hold on just a second. I think you might have to transfer the control for us, Dr. Mistry. If you'll just click Doctor. There, you're speaking there, Dr. Wood?
Yes, you have my audio. I still can't start my video. It says the host has stopped my video.
If you'll right mouse click his name, Dr. Mistry, and just click make Dr. Wood the host. It's always fun when we're getting through these. There we go.
Hey. All right. Thank you, Dr. Mistry. I'm going to share my screen as well. And okay, there we go. So we've got my slideshow up there. Dr. Mistry, I want to thank you so much for doing this webinar with us. You know, as an industry secret for everybody, doctors can get stuck in ruts, and it's best to not see a doctor like that. It's impossible to know. But I'll tell you, the Dr. Mistry is always looking for what's next, what's better for his patients. He's truly an out-of-the-box thinker, and he's very collaborative with us, and I know with all specialties, in getting together and just talking about what can we do to present the best options for our patients. Like he said, there's no one right answer for every patient, but every patient should hear an honest assessment of all of their options. And you'll get that from Dr. Mistry, I can tell you that. Be sure to check out his radio show. If you didn't see a banner over behind his shoulder, that's Saturdays at 3 p.m., the Armor Men's Health Hour on 590 AM KLBJ. So check that out. We'll be glad you did. So let me know if you can't see my screen, Scott. We're going to talk about prostate artery embolization. That's something I do as an interventional radiologist. Basically, that means we do procedures through the blood vessels. So we treat abnormal blood vessels, but we also treat abnormal organs using the blood vessels as an avenue into that organ. And so we'll talk more about how that works. So we've got treatments that we do for virtually every organ. We get into the organ through its blood vessels and administer various kinds of treatments depending on what problem that organ is having. So let's launch into what we can do for the prostate. This has been studied for many years, at least 10 years, but prostate artery embolization has been commercially available for just a couple of years now. So it is thoroughly studied, commercially available for a couple of years. It's given us a chance to climb the learning curve in the unique kind of pearls and pitfalls to treating the prostate. And I can tell you that our company, Advantage IR, has been an early adopter in climbing that learning curve. And we've treated dozens and dozens, even into the hundreds of patients now. And you want somebody who has done it a lot. You know, if you take nothing else away, you want doctors that have done procedures or surgeries a lot. So let's talk about a patient that I saw early on. This was a surgeon who came to me. He was retired and he had BPH problems. He had trouble in his life hanging out with his grandchildren, making long drives, getting out onto the golf course. His BPH was interfering with all of these things. And so you might have seen a form like this. This is called the IPSS symptom score. And it kind of lists, it's a useful listing of all the symptoms that BPH can cause. Over here along the left, you can give yourself take this yourself and give yourself a symptom score. You can find that this patient's score was 23, which you can see is in the severe end of the range. And as far as disruption to his life, he was mostly dissatisfied in his quality of life score. We're going to talk about this at the end of my talk too. So let's note the quality of life score. Low scores are better. Delighted is best, which is a 0. 6 is bad. So his score was 4. So he had all of the typical symptoms of BPH. Basically, they all come down to obstructing the flow of urine out of the bladder and through the penis when you go to urinate. So this was the same patient. We're going to keep talking about this patient. This was his MRI. I don't usually get MRIs on patients before treating, but this patient happened to have MRI, and it's useful to look at. He had a 200-gram prostate, and so this is looking at this patient from the side. We're looking at him from the side. So this is the bottom of his sacrum, and this is the pubic bone. This is the bladder with urine, which shows up white on MRIs, and this is his prostate. He had a 200-gram prostate. Dr. Mistry talked about prostate sizes. This patient was very large at 200 grams. And you can see how a prostate that size is bulging up into the bladder and causing an upward compression deviation of the bladder. I just put in this MRI as in a normal sized prostate, just for a comparison. You can see the prostate should be sitting under the bladder and not compressing the bladder's contour at all. So this is a cross-sectional view of that same patient. You can see the size of his prostate on this transverse or cross-sectional view. So this is the front of the patient. This is the back lying on a table in the MRI machine. This is the bladder, right hip, left hip. Prostate markedly enlarged. You can see comparison to a normal prostate should look like that. This was enlarged with just BPH, just prostate hyperplasia. MRIs are useful in that they can help rule in or rule out prostate cancer. This patient did not have prostate cancer. But you can imagine the urethra draining urine from the bladder needs to run right through the middle of that prostate. And if the prostate enlarges to this degree, you can imagine that the urethra is going to get squeezed shut. And that's what causes the symptoms that we've talked about. So what can I do? What can I possibly do with blood vessels to fix that? Well, we use the body's circulatory system to influence the function and size of organs. And we've known for many years that if we slow down the blood flow into an organ and slow down the arterial blood flow, specifically the arteries blood flow into an organ, that organ will shrink. And that's true of any organ. And it's been found to be just as true for the prostate. The question is, does it cause harm to the organ? Some organs we couldn't do this to, but the prostate's one of those organs that are not as sensitive to having its blood flow slowed down, and it does not do harm. And we'll talk about that more. So when we're setting out to treat a patient like my patient, the surgeon, what we want to do is get into the blood vessels somewhere. And on this diagram of the circulatory system, let's focus on red. These are the arteries. All of the arteries in the body are connected to each other. So if we enter the arterial system somewhere, we can get to any other artery. We could go to the intestines, the brain, the liver, the spleen, and so in this case, we choose to navigate to the prostate arteries. So we usually enter the right femoral artery, that would be here, right over the hip, right over the head of the femur. And when we enter there, like we see on this cartoon, we can navigate. And what we would do is navigate into the prostate artery by going up to the aorta and then back down into the pelvic arteries and ultimately into the prostate artery. So doing all this, it is a procedure. It's a strictly endovascular procedure. So I'm careful to tell patients right away, I'm not going to touch your penis. We're only going to touch you at your groin. We're not going to touch you down there at all. And that means no bladder catheter. The procedure can take a couple of hours. We give mild sedatives to make the patient comfortable while we're doing this. And we watch the patient for about 90 minutes afterwards and then let you go home. So that's a little bit about the procedure. It's all done through one groin puncture. Sometimes we do this through the radial artery. If you can still see me, I'm pointing to my left wrist. We can go into the radial artery and then navigate to the prostate arteries from there, depending on the patient's height. So let's say we're in the middle of this procedure, we're treating our patient's 200-gram prostate, and we're navigating through the arteries over to that left prostate artery. There's a left and a right prostate artery, one prostate gland, a left and a right prostate artery. We need to treat them both. So we've navigated on these are the actual pictures from treating this patient with the 200-gram prostate. We've sent a catheter up from the right femoral artery and down into the left pelvic arteries, and we inject contrast dye. So what's showing up dark here is contrast dye. And the computers have largely subtracted out the bones, but you can make out a little bit of the bones of the pelvis here. And you can see the prostate artery on the left winding its way through the pelvis towards the patient's midline. We need to get into that. So we're going to send a little angel hair pasta sized catheter. By catheter, I just mean a long, skinny, flexible tube. This is not a bladder catheter. This is an arterial catheter we're talking about. And this one is very tiny to get into this little artery. And here we've done that. This is that microcatheter. It's the size of an angel hair pasta. It's in the prostatic artery, and we're injecting contrast dye. You can see the contrast dye as it moves through the prostate tissue. What we see, this dark haze, is actually contrast in the capillaries of the prostate. So we've got the bigger branches of the arteries of the prostate branching and branching into smaller and smaller levels until ultimately they are in capillaries. And so we see a nice hemi, or half of the prostate here, with this sharp margin along its midline. Let's put up that view of the MRI looking from the front of the patient. You can see how we're treating half of the prostate here, which is like half of a heart shape. And you can see the same thing here. So whatever we do here, it's going to treat the whole prostate. And so now we need to decide, what are we going to do to treat this prostate to make the BPH go away, right? So that's what it's all about. So this is a common site in Arizona, where I'm from. These are rocks lining a wash in people's backyards. And just about everybody's backyards, especially in Scottsdale, has a wash like this. So the rocks are there to to protect your backyard from flash floods, which do happen in Arizona. And so the rocks are there to slow down the velocity and energy of moving water. And so we kind of use the same principle in arteries to slow down the velocity and energy of moving blood, to slow the blood flow down into, or way down into organs, and which ultimately makes that organ shrink. However, a little bit of blood flow still gets into the organ, so we're not completely cutting off or killing the organ, but we are cutting the blood flow down probably 95%. A little bit of blood can still get through here, but we do use little gelatin beads. These beads come in syringes like this and are graduated to give us a really predictable, consistent diameter bead. These beads, this is a 700 micron syringe. There are thousands of beads in here. They're all 700 microns. That's 0.7 millimeters is 700 microns. For the prostate, we actually use about 300 micron beads, or 0.3 millimeters. And we just take this syringe and we attach it, and we're going to see what the beads look like. The beads float. They float in fluid and they float in blood. They will go wherever the blood is flowing. So we release the beads in the main prostate artery, and it's your blood flow that takes the beads into the prostate where they belong. So we're going to take our syringe of beads and we're going to inject it through the catheter that we've positioned in the prostate artery and let them go to work. Now this cartoon shows that we've gone into the left groin. We don't do that. We do it all from the right groin or from one groin puncture. The beads then float along the bloodstream, and they are small, but they eventually reach a vessel size they cannot pass through, and they get stuck. And they do form a column like my previous picture showed. That slows the blood flow down, way down into the prostate. We've done that we've attached our syringe of beads and treated the left prostate artery now. Now we're moving on with our procedure and our 200-gram prostate. We're going to treat the right side. How can we do that? From the same side, we can actually loop our main arterial catheter up into the aorta and bring the tip down into the prostate artery. And we've done that here. Here's the tip of my main angiographic catheter. It's going in through the femoral artery, looping up into the aorta, and the tip is back down in the pelvic artery here. We've injected contrast dye. We see the prostate artery is right here. And it takes some experience to recognize which of these several arteries that we're seeing here is the prostatic artery. But that becomes a simple matter once you've done this for a while. So we're sending our microcatheter into the prostatic artery. We've done that here. We're injecting contrast dye. Again, we see that nice we're now treating the right hemigland or right half of the prostate artery. You can see our correlate with the MRI. This is what gives us the confidence that we're treating the prostate and not another organ of the pelvis. So we've injected our beads and we're done. This is what it looks like when we're done. We've left the parent artery, the main prostate artery, open on the right and on the left. But we don't see those branches into the prostate anymore. There's actually a little bit of blood flow, a trickle of blood flow still getting into the prostate. Here's a before and after on the right and before and after on the left. This is how we leave it. And our treatment is now done. And so what happens over the next week or so, the prostate shrinks. And so after about a week, the patient can start to feel their improvement in their urinary flow. Those improvements keep setting in and the prostate keeps shrinking until about 1 month. The patient has experienced much of their benefit by 1 month. It keeps improving out to month 3, and then you're basically set. So by 1 month, and really especially by 3 months, the patient has their maximum benefit. But they start feeling those benefits right away. But what happens in the prostate? MRI studies show that the prostate shrinks, though. So this is not our patient. We did not do an MRI after treatment, but this is a before and after MRI of a patient from a study. It shows that the prostate is smaller. I think we can appreciate that the prostate has shrunk. And there are little cystic spaces in the prostate, which are probably little dead spaces that have resulted from the embolization. But all in all, the prostate is still alive. There's still living prostate tissue here, and most importantly, the prostate keeps doing its job. The prostate is a sexual organ. Its job is to make and store semen, and it keeps doing that seemingly without interruption. So this patient came back at 6 weeks, and this was his final IPSS score. It was 7. He scored himself. He filled this out. He scored himself 1s for all the questions, and he had a score of 7. As a reminder, his initial score was 23. His quality of life score went from 4, mostly dissatisfied, to 0, which is delighted. So we want quality of life scores to go down, and we want IPSS scores to go down. And that's relevant for the next couple of slides. I'm just going to show you what have studies shown real briefly. There have been randomized controlled trials that have taken patients and randomized them to either prostate artery embolization or TURP. Because TURP is the gold standard surgery for BPH. So PAE, embolization, has mostly been compared with TURP. And what are the outcomes of each group? Well, this is what the results from one study showing the drop in the symptom score in both groups, the embolization and the TERP group. And you can see that this is at month 3, 6, and 12. So these results are sustained for 12 months and beyond. We can achieve these results, these improvements in symptoms without using a bladder catheter, without sexual side effects, and without any time in the hospital, completely outpatient. We ask for 2 days of light activity after our procedures, but basically life back to normal the next day. There are some side effects to deal with, some burning when urinating, and some increased urgency to urinate are the most common side effects after embolization, and those can go on for a few days. We give prescriptions to the patient to keep them comfortable through those side effects, and with the exception of those side effects and light activity, 2 days, life can return to normal really quickly. This is the flow rate. Qmax is the maximum flow rate. If you were to measure the flow of urine when you urinate in cc's per second, you can see that improving in both the embolization and the TERP group, and seeming to improve equally. This is the change in quality of life score. You see that improving. We want to see lower numbers going down in quality of life. See that improving in the embolization and the TERP group. So in many ways, in most ways, we can give patients results that are similar to TERP without using, with a much easier procedure, if you will, with no bladder catheter, no sexual side effects, and home the same day, a totally outpatient procedure. So you're not sacrificing good results, is my point. You can get great results with embolization with the benefits I just listed. So with that, I'd like to ask Scott if we have any questions or anything else we can address.
Yeah, we have a few questions here. Everybody, you're hearing me, Dr. Wood?
Yep, I hear you.
Great. So let me go through a few of these. First, from Daniel. Collateral circulation. Does the effectiveness of PAE over time decrease as the prostate circulation remodels?
Yes, and that probably is why PAE does need to be repeated. And it's in fact true, Dr. Mistry can speak to this, but any treatment that leaves prostate tissue behind is going to have a recurrence rate. So basically all prostate treatments have a recurrence rate because the prostate is always growing. Men, sorry to say, that's true for all of us. The prostate's always growing. It's true for embolization as well. The prostate does recruit new blood vessels into itself, and the prostate does keep growing. And so there is a recurrence rate. It seems to be about 5 years, where the average patient would need retreatment at about 5 years. And that's very similar to most of the other minimally invasive treatments for BPH these days.
Next question. I have a stent and pacemaker, also varicocele on left side, and tourniquet caused varicose vein entire length. Is PAE a good candidate for me, or should I come in and see you?
You should come and see us. Everybody should come in and see us, and we would go through patients' comorbidities, case by case. But from what you described there, I don't see any reason PAE couldn't be done.
If a patient has had a vasectomy, will this procedure impact the volume of prostatic fluid, reducing ejaculate volume? And does it make a significant impact on improving problems with delayed or difficulty in achieving ejaculation?
There are probably no effects on the ability to ejaculate, or there doesn't seem to be any retrograde ejaculation. There are some studies that show possibly a decreased volume of ejaculate. The jury's still out on that. If there is a decreased volume of semen, it's a very small decrease, and it's, I think, minimally perceptible to a patient to reach a patient's awareness or perception that they have a smaller ejaculate volume. So jury's still out. If there is any sexual side effect, it is that there may be a decrease in ejaculate volume. no other effects on sexual function, no effect on erectile dysfunction. And studies have actually shown what Dr. Mistry has described as his own anecdotal observation, that patients can have an improvement in sexual function and erectile function after a PAE.
After the procedure, do you still need to take alpha blockers?
We like to try to stop the alpha blockers, and so it kind of depends on where a patient is starting. If a patient's symptom score is way up in the 30s, we can get that score down about 10 to 15 points. And if my screen is still sharing, I like to show this to show that this patient's total score was 23, but the possible maximum score is 35. I tell patients that we can get your score down by between 10 and 15 points. So, and a patient who's at 23, we actually got him down by 16 points to 7, and he was delighted with those results. But let's say a patient was starting at a score of 33, and we got his score down to 17. Well, he may not be as delighted with his results, and a patient like that may still need his alpha blockers. But I can tell you that most patients are in the 20s, and we are able to stop alpha blockers in most patients. We wait 2 weeks. So we do the procedure, we wait 2 weeks, and then we go to every other day alpha blockers. The Flomax is an example of a common alpha blocker. So we have the patient keep taking it 2 weeks. Then at the 2-week mark, we have them go to every other day. And if they're doing well, then we have them stop.
I'll tell you that the likelihood of getting off your alpha blocker is about 80%, is when I quote patients. So, and the bigger the prostate, the more likely you are to get off the alpha blocker, just because decreasing the prostate size by 40% is more of a impact when it's really big.
I had a Eurolift procedure done a few years ago. Are there any issues with tissue remodeling in the clips that are in place?
In my view, there is no issue with any prior prostate treatment, including Eurolift. Now, maybe we can, so that means that anybody who's had a previous prostate surgery is a good candidate for embolization. I would like to ask Dr. Mistry, because I get the question a lot, what will happen to the tacks or the clips or the staples that you use after embolization? Could something bad happen to those? And I tell patients no. Hard to imagine anything bad happening to those tacks, but Dr. Mistry, do you have any experience to speak to that? It's a very common question.
Sure. So, and the reason it's common is the same kind of patient that ultimately decides to get a Eurolift is very similar to the kind of patient interested in the prostate artery embolization. Somebody trying to minimize sexual side effects, trying to go with a least invasive approach. So these two types of patients overlap quite a bit. In terms of what's going to happen to the clip, in your mind, you might think of these clips kind of floating in space. And then when you shrink the prostate, one of the clips might be kind of hanging out or swinging in the breeze.
Right.
But that's not what happens. With just a few days, the clip that's on the inner surface of the prostate actually grows into the prostate. And so when it shrinks, it just moves along with it as it shrinks. So there should be no risk of having a side effect from a clip once the prostate shrinks.
Very good answer. Thank you.
Few more questions. We really do appreciate these questions. These are great. This is a really good one. Can this be used to kill the prostate completely for people with prostate cancer as an alternative to removal?
That is being studied, giving treatments through the arteries. It's not unprecedented. This is actually the first choice treatment for liver cancer. And by that, I mean cancer that arises from liver cells, primary liver cancer. The primary first choice treatment is what we call chemoembolization, chemotherapy that we deliver on beads, very similar to the beads we use in the prostate. That is being studied in the prostate, and the results so far, it's very early, the results so far do not support this being a new standalone treatment for prostate cancer. It does partially kill the cancer, but it doesn't kill all of it. So right now it's investigational. Maybe someday this will be a treatment for prostate cancer, but right now it's not. But there are other treatments for prostate cancer, such as HIFU, that can work better if the prostate volume is decreased. And so we have worked with Dr. Mistry to use embolization to decrease the size of the prostate to make his HIFU treatment more effective.
Yeah, and to that end, I'll say that there is a real benefit also in patients who are going to undergo radiation therapy to the prostate to reduce prostate size. And so there is, although it's not killing the cancer, we certainly feel that there's a strong reason to think that by stunning the prostate cancer, by taking away its blood flow, it's going to respond better to both high intensity focused ultrasound and radiation to kill it.
Awesome.
We have several questions related to insurance. The big one from 3 people is this covered by Medicare? And then secondly, what has been your experience in various insurance coverages covering this, especially as we look at the end of the year, deductibles being met? Is this an option for people?
It certainly is covered by Medicare, and it's covered by most commercial insurance. We have not had trouble getting it covered by Medicare Advantage plans. So I would say Medicare patients are set. Now we have had trouble with Aetna in Texas. So we have challenges with Aetna in Texas. That being said, we try to fight for every patient. So I would not use that as a reason to not at least talk to us about this and see what we can do. All other commercial plans seem to be covering it without a problem.
Another question that popped up, especially as we look at the end of the year during this time of COVID, what types of precautions are you using in your clinics to make sure that if I do come in because I've met my deductible, that I'm going to be safe?
Oh, absolutely. We are doing everything that we are supposed to keep patients safe. We're separating our appointment times so that a patient entering the building is going to be entering by himself. We take patients straight to the consult room. And then first, we didn't mention, but we first consult with patients to go through the procedure and make sure the patient's a candidate, answer any questions they have. So the first time we would meet you is on consult day. We bring you straight into the consult room. Everybody in the building has masks. Everybody in the building has been verified to not be sick and not have a fever. We also check all patients and family members coming into the building. Once we're with you, of course, you're the provider, and every staff member you talk to will have a mask on, lots of hand sanitizing going on. And then on procedure day, the same thing. We separate patients both in time and in space, and we make sure that our staff members are well that day, and that way we have not had an issue with COVID in any of our centers, and we plan to keep it that way through just smart planning.
Great. Joining a few questions together here. Looking at the long range results that you've seen in 5 and 10 years, what do those look like? And are there cases where you'd have to do a second PAE?
Yes, it does look like long range studies are showing there is a recurrence rate, and those studies that are going out that far have mostly come from Brazil and Portugal. And so one of the Portuguese investigators, who was one of the original pioneers in embolization for the prostate, said at a conference that to him it's looking like 50% of patients will need retreatment at 5 years.
Is there a burning sensation during urination common with BPH for either doctor?
Just as a, now that is a side effect of embolization, but it sounds like the question is asking, is that a common feature of BPH alone, notwithstanding any treatment? Not that I know of. Maybe Dr. Mistry can speak to that better, whether dysuria is a symptom of BPH.
We have you on mute, Dr. Mistry, if you're trying to talk.
He may be away from his microphone at this time.
All right. Let's jump to another question. We might be able to get back to that once we get to his microphone connected, technical difficulties there. Can you provide a timeline for the process from the initial visit to if I'm diagnosed with BPH and a candidate for PAE to having the procedure? Is this something that happens in 24 hours or 2 or 3 weeks from start to finish?
It can happen in 24 hours, but it depends on what kind of workup the patient has had in the past. And a patient who has had a thorough workup with a urologist, we can determine that that patient is a candidate and even get the procedure scheduled the next day. If a patient has not ever seen a urologist, that's kind of on the other end of the spectrum. A patient who's never seen a urologist really should. A man really should see a urologist about these symptoms. And the reason is these symptoms are not always caused by BPH. And so we don't want to just assume that if a patient comes in with, this list of symptoms, incomplete emptying, weak stream, that BPH is the cause. Sometimes urologists decide to do some tests, and sometimes they don't. And then also a urologist should do some responsible prostate cancer screening. So we like all of our patients to have been seen by a urologist in the recent past. So if a patient has had that done and we can get those records, then we could go from consult to procedure in as little as 24 hours. We also have some insurance pre-authorization to do there, but for Medicare, let's say a Medicare patient comes in and we can get their urologist records and everything looks good, that the cause of the symptoms have been found to be BPH, as a conclusion by the patient's urologist, then yes, we could do this 24 hours later. For patients who have never seen a urologist, we usually send them to Dr. Mistry or to another urologist of their choice to talk about options and make sure that the appropriate workup has been done to determine the cause for the symptoms.
I have another question here. A little specific, but let's see what we can get out of this one. I'm supposed to get a Eurolift soon, size 32 prostate. My PSA is very low. One of your doctors did a scope on me, assuming that's a Dr. Mistry patient. But for 20 years or so, I've had very low free testosterone, but have been afraid of taking testosterone. Will it be safe to use testosterone after a Eurolift or this procedure?
Scott, I'm back. I can just tell you guys that there's no risk of taking testosterone after this procedure. And by the large, very few patients actually have worsening of urinary complaints after starting testosterone. But certainly even fewer people are going to have trouble after a PAE if they start on testosterone.
Thank you. Dr. Wood, how many days is usual for the burning urination after the procedure is completed?
We tell patients it could be 7 to 14 days. Now, the 14-day end of that spectrum will be larger prostates. I have found that the side effects go along with the prostate size. So that's my own observation, but it seems to be true. So I tell patients with very small prostates, and we are developing a minimum size of about 40 grams. That's largely based on our experience and Dr. Mistry's recommendation, and I agree with him. So a patient who is, say, a 50 gram will probably experience very minimal side effects, and some patients have experienced no side effects. So let's say the larger you go, over 40 grams, the more side effects you'll have, from 0 to maybe a couple of days of dysuria and urgency, on up into the spectrum with a very large prostate, say 200 grams, we're probably looking at a couple of weeks of dysuria and urgency.
Great. Joining a few questions here together again, thank you for all the questions everybody's sending in. For patients with high blood pressure, are there any additional risks? And how many procedures has Advantage IR done of this type of procedure?
So our procedure numbers are now into the hundreds for prostate artery embolization. At our Austin center, this is by far the most common procedure we do. We do about 5 a week. I can tell you right now, sometimes even 6 a week. And the other quote was high blood pressure. To the extent that the patient has normal cardiorespiratory function, there's no risk of doing our procedure, even in a patient who has high blood pressure. But it's in the details. We want to make sure that the blood pressure is well controlled, and that it's not the tip of an iceberg of a larger cardiovascular or cardiorespiratory problem going on that should be addressed before the patient undergoes this or any other procedure or surgery, and we would determine that at consult.
I guess I kind of love this question, but it seems to me that reducing the size of the prostate would be better than the Eurolift system. Is that true?
I wouldn't say that's absolutely true. I think it's in the details. I think that, like we've said, we have a minimum size. So if the prostate should be around 25, 30 grams. If you have a prostate that's just slightly over that, but has built up bulky tissue around the urethra, that Eurolift might be best for that kind of patient. In my mind, a Eurolift is probably better for a patient who has very minimal prostate enlargement, but yet still has BPH symptoms. The embolization benefits start to go up once we get over 50-gram prostates.
Let's see here. I think we're slowly running out of questions. I'll take this one. How do I make an appointment? If you are interested in making an appointment with Advantage IR so we can see you in our offices and have one of our doctors do a consult for you, you can visit our website at www.advantage-ir.com. And there's a form within the website that allows you to submit an appointment request, or even better yet, we have people that are standing by the phones at all times to talk with potential patients. Our phone number for our Cedar Park office is 512-772-1677. Alternatively, if you need to talk with Dr. Mistry first, Dr. Mistry, if you're still on here, can you give us your phone number for your offices? I think we may have lost him. It is on the last slide of our deck. We do have the NAU urology phone number on there so that we can get you in there. Again, any way that we can help you. We are also going to, as being a member of this webinar, we'll send you a quick email or phone call just to follow up to see if there's any way that we can help you out, and one of those people will be in touch with you. So if there's anything we can do, we're happy to help you out and hopefully make your quality of life better.
I'd also say, Scott, sorry to interrupt. We have lots of information on our website, and we have videos on our YouTube channel. Go to YouTube and search Advantage IR. You can see some short and also very thorough on the long side videos for those who are looking for lots of information.
And if we've missed any questions or there's some very specific questions, again, we encourage you to reach out to one of our offices depending on which stage of this process you are looking at. If you fill out the form on advantage-ir.com and talk, there's a spot where you can put in information, specific questions, so that we can get back to you and get those answers to you. So I think we're at our full hour here. I'd like to thank Dr. Mistry for his time. He had to leave at the very end for a patient. Thank you to Dr. Wood for his time. And especially we'd like to thank all of you that attended this webinar today. We hope that it's been informative and that there's a way that we can help you and improve your quality of life. So thank you very much from all of us, and we look forward to talking with you more.
Thank you, everybody.